Good afternoon. My name is Lisa Ambrose. I am a clinical research specialist with Spectrum Health's emergency medicine research team. Today, I am here to share with you our study on pediatric vulvovaginal lacerations in a community-based population. The investigators on our team have no financial relationships to disclose. So to begin, genital trauma is generally uncommon in girls. These injuries are often caused by direct blunt trauma where a highly vascular region is crushed against osseous planes. In previous studies, several mechanisms of injury have been described and include straddle, crush, or shear injuries, accidental penetration, and sexual abuse. In these cases, injury severity and location are generally influenced by the mechanism of injury. Known female physiologic characteristics such as elasticity of the vagina and perineum are also contributing factors. Common locations of this type of injury include the labia, posterior fourchette, and the perineum. Minor superficial lacerations generally require only conservative non-surgical treatment, while surgical intervention is reserved for more deep penetrating lacerations or tears. Our study objective was to describe the mechanism, injury pattern, treatment, and the outcome of lacerations to the female genital tract in children and adolescents presented to the emergency department. This study was a retrospective cohort analysis concentrating on an 8-year period from 2012 to 2019 and covered children ages 1 to 15 years who were presented to any of 7 affiliated hospitals in West Michigan and diagnosed with vulvovaginal lacerations. All of these patients were examined by board-certified emergency clinicians trained to perform medical legal examinations. Data collected included the mechanism of injury, any clinical findings, subsequent treatment in the ED, and the patient's final disposition. Any procedure or operative notes were reviewed to define the extent of the injuries and the time and type of definitive treatment. Descriptive statistics were used to summarize the data. During the study, 912 children were evaluated for genital trauma. Of these children, 201 presented with vulvovaginal lacerations, and the mean patient age of this population was 6.3 years, with a plus or minus variation of 6.4 years. Mean time to presentation with injury was 5.7 hours plus or minus 4 hours. Straddle injury comprised most of the cohort with 154 patients documented to have straddle injuries. These straddle injuries were incurred on a wide variety of common objects and no specific causes appeared to predominate. Additional causes included 16 falls, 10 blunt trauma injuries from motor vehicle accidents, 7 accidental penetrating injuries, 4 injuries from sexual assault, and 10 mechanisms categorized as other. We found that wound locations documented during this time were to the labia majora and minora in 68.7% of subjects, the posterior fourchette or perineum for 18.9%, or in 12.4% of subjects to the hymen and or vagina. 56.2% of lacerations were superficial wounds ranging from 5 millimeters to 6 centimeters, with a mean length of 1.1 centimeter. 34.8% presented with deeper lacerations that were repaired in the ED using procedural sedation. Gynecologic consultation was obtained for 74 of the 201 subjects presenting with injury, and 9 children were taken to the operating room for surgical repair. The increased need for operative intervention in these subjects was generally due to the uncontrolled bleeding, poor visualization of the injury site, young age, or a combined injury to the vulva and vagina. The postoperative course in all of these patients was uneventful. The limitations of the study was primarily the narrow availability of data to conduct the research due to our retrospective approach, as it doesn't allow for analysis of treatment choices and their corresponding outcomes. In conclusion, we found that the majority of vulvovaginal lacerations in children are minor and resulted from stratal injuries. In this community-based population, 35% had lacerations that were repaired in the ED, and only 4% of children required operative intervention. Uncontrolled bleeding, a subject's young age, poor visualization, or an injury that included both the vulva and vagina increased the need for surgery in this population. Thank you for your time today, and I'm open for any questions.
Hello, my name is Kevin Molyneux. I'm a second-year resident in the emergency department at Mount Sinai Morningside and West, formerly known as St. Luke's Roosevelt. Today, I'll be presenting our data on the utility of measuring serum creatinine to detect renal compromise in ED patients receiving IV contrast-enhanced CT imaging. We have no financial conflicts of interest to disclose. As some background, about 7 million ED patients per year receive IV contrast-enhanced CT imaging. Those with underlying renal disease are at risk for developing contrast-induced nephropathy. CIN is defined as an elevation in the baseline creatinine greater than 25% within 48 hours of receiving the IV contrast. Outpatient studies have demonstrated that 12 to 26% of patients with underlying renal disease will go on to develop CIN versus 3% of those without underlying renal disease. So serum creatinine is often measured pre-CT scan to risk stratify patients and assess the risk of developing CIN. Our objectives were to determine the rate of underlying renal compromise in ED patients undergoing IV contrast-enhanced CT imaging, and to determine the efficacy of a roster of clinical factors to identify those patients at risk and help mitigate the need for lab evaluation to determine their pre-CT renal function. So we performed a retrospective chart review of consecutive patients who had IV contrast-enhanced CT imaging and had a pre-CT serum creatinine that was measured between January and April of 2019. At our institution, it's our protocol to measure a serum creatinine before contrast-enhanced imaging for all ED patients to assess the risk of developing CIN. This can be overrode by a physician in the event of something like a stroke or a dissection where the imaging takes precedence. We define an abnormal serum creatinine as greater than 1.4, which is supported by outpatient radiology literature as a marker of impaired renal function. For our power calculation, we determined that we needed 996 cases to achieve 80% power to determine the significance of a difference in rates of serum creatinine above 1.4 between those with and without risk factors. For our results, there were 2,260 patients who had IV contrast-enhanced CT imaging performed within our study period. 99.6 had a serum creatinine measured. 6.2 had a serum creatinine greater than 1.4, which we defined as our cutoff as abnormal. 3.3% had a serum creatinine greater than 2.0. And of the 141 with an elevated serum creatinine, 139 had an underlying medical condition, which is 98.6% of the patients. These are the clinical factors that we use to define a patient as being at risk. We added typical renal disease, hypertension, diabetes, but we also added shock and chronic alcoholism, as shock can often cause an AKI in the ED, and chronic alcoholism can often be difficult to obtain a reliable history from those patients. Of the 141 with an elevated serum creatinine, 122 had more than one associated underlying medical condition. 2 patients, which was less than 0.01% of our entire cohort, had an elevated serum creatinine and no underlying medical condition. They underwent IV contrast-enhanced CT imaging, and repeat creatinine measurements were normalized after. Neither required dialysis. Over the 4-month period to perform the serum basic metabolic panel, it cost, we estimated, about $94,500, which extrapolates to over $250,000 per year. So in conclusion, an elevated serum creatinine is rarely present in ED patients that receive IV contrast enhanced CT without some recognized risk factor on the history or exam. Routine serum creatinine measurement on all ED patients, regardless of their pre-CT risk stratification, based on our data, is neither time nor cost effective. Thank you.
Hello, everybody. My name is Eric McDonald. I'm a third-year medical student at the Albert Einstein College of Medicine in the Bronx. Today, I'll be talking about my project entitled Opioid and Non-Opioid Prescription Patterns for Emergency Department Visits Associated with Urolithiasis. I have nothing to disclose about this project. So over 1 million patients are treated annually for kidney stones in the United States emergency departments. Opioids are commonly prescribed due to the acute presentation and severe pain associated with kidney stones. However, there's a lack of clear guidelines for pain management for urolithiasis at this time. Of course, the opioid epidemic is an ongoing issue here in the United States and across the world. And we as physicians, medical students, and healthcare workers play a very unique role in this crisis. One study has shown that 59% of patients with an opioid use disorder first received these opioids from doctors, and 29% of these patients received them from the emergency department. Physicians are beginning to use non-opioid alternatives, such as ketorolac and acetaminophen, in the setting of kidney stones in the emergency department due to increasing awareness of the consequences of these opioid medications. Additionally, previous studies have shown that certain factors such as race, specifically Hispanic Black race, can actually affect the likelihood of receiving opioids for this condition. The objectives of our study, we examined the national opioid prescription trends for ED visits related to urolithiasis during this time of increasing awareness of opioid-related risks. We then aimed to identify whether urban and rural status, age, region, race, insurance status, if these factors affected the likelihood of receiving opioids in the emergency department for kidney stones. For our methods, we extracted the data from the National Hospital Ambulatory Medical Care Survey, or NHAMCS. We looked at all ED visits between 2006 and 2016 for kidney stones in the emergency department setting. We were then able to use weighted estimates from the NHAMCS database that extrapolated to ED visits in total for the United States. We then extracted age, race, geographic region, insurance status, urban versus rural hospital status. Additionally, we categorize prescriptions as opioid or non-opioid. And lastly, we use chi-square testing to assess for differences between these two cohorts. For our results, so we ended up examining over 12 million extrapolated patients. Approximately 5 million, or 41.6% of these patients received an analgesic prescription, with approximately 3.8 million of these patients, or 31.4%, receiving an opioid medication. 1.2 million patients approximately, or 10.2%, received only non-opioid analgesic pain medications. We found that urban hospitals had a higher prevalence of opioid prescription use at 3.9 million patients compared to rural hospitals at 3.2 million patients. This had a p-value of 0.0176. We also found that age, race, ethnicity, geographic region, and insurance status did not have any statistically significant associations in the likelihood of receiving an opioid or non-opioid medication. So in conclusion, we found opioid prescriptions for urolithiasis-related visits were more commonly written in urban EDs versus rural EDs in the United States. Given the recent disproportional increase in opioid-related deaths in urban settings, it is very necessary to start introducing further education, specifically in these urban emergency departments, to prevent the overprescription of opioids for these patients. Of course, we also need future research to continue to examine opioid use in the setting of kidney stones in the emergency department. The study did have some limitations. First of all, it is a retrospective study. Secondly, there was some inconsistency in the collection of certain variables For example, there was no reporting of urban versus rural setting in the 2012 data set. And lastly, we were not able to distinguish between new prescriptions for opioids versus prior prescriptions of opioids during previous ED visits. The main strength of this study was that we had a decade of data from a large national database. This allowed us to have a very large sample size and study population. I would like to thank my fellow medical student at Albert Einstein, Denzel. I would also thank my PI, Dr. Kara Watts in the Montefiore Urology Department. And I would also like to thank the SAEM for allowing me to present our work today. These are my references for this talk, and I'm happy to take any other questions at this time.
Hello, everyone. I am Samuel Garcia, and I'm an emergency medicine resident at the Mayo Clinic in Rochester, Minnesota. I am excited to talk to you today about a project which is titled Learning Curve for Laryngoscopy Devices in Emergency Medicine Training, a National Emergency Airway Registry study. I want to take a moment at the start of this presentation to express my gratitude to the outstanding team that I've had the honor and privilege to work with. In emergency airway management, we know that securing the airway during the first attempt is crucial to mitigate peri-intubation adverse events. In academic emergency departments, it is the emergency medicine residents that perform the majority of endotracheal intubations, so they must be adequately trained and skilled with a variety of laryngoscopy devices. The three most common laryngoscopy devices used in the emergency department are the direct laryngoscope, capable of performing only direct laryngoscopy, the hyperangulated blade video laryngoscope, capable of performing only video laryngoscopy, and the standard geometry blade video laryngoscope, capable of performing both direct laryngoscopy and video laryngoscopy. Each laryngoscope requires different intubation techniques to achieve glottic exposure, endotracheal tube delivery, and tracheal intubation. Each laryngoscope, therefore, likely has a different learning curve, although there are limited studies examining the learning curves across these devices. The objective of our study was to compare the learning curve of the direct laryngoscope, hyperangulated blade video laryngoscope, and standard geometry blade video laryngoscope during emergency residency training. Our study analyzed prospectively collected observational data from the National Emergency Airway Registry from January 1st, 2016 to December 31st, 2018. We evaluated only first attempt oral tracheal intubations performed in adult patients by emergency medicine trainees using the direct laryngoscope, hyperangulated blade video laryngoscope, or standard geometry blade video laryngoscope. Emergency medicine trainees were categorized by postgraduate year of training into PGY1, PGY2, or PGY3+. PGY4 and PGY5 trainees were included in the PGY3+ group. We then used mixed effects logistic regression to determine association between postgraduate year of residency training and first attempt success by device. Here, we present our inclusion criteria and enrollment strategy. A total of 19,071 intubations were recorded in the NEAR database during our study period. After applying our exclusion criteria, a total of 15,204 intubations were included in our study. In analyzing each of these encounters, the mean age of our patients was 55 years, and 65% of them were male. Operators reported anticipated airway difficulty in 32% of encounters. The majority of the intubations were performed in medical patients, with the most common indications for intubation being trauma, non-overdose related mental status changes, cardiac arrest, and overdose. The standard geometry blade video laryngoscope was the most commonly used laryngoscopy device, used in 42% of all first attempt oral tracheal intubations. This was followed by the direct laryngoscope, which was used in 31% of all first attempts, and finally the hyperangulated blade video laryngoscope, which was used in 25% of all first attempt intubations. In this figure, we present first attempt success by postgraduate year of residency training for each laryngoscopy device. In the y-axis, we have first attempt success reported as a percentage. In the x-axis, we have postgraduate year level of training. The direct laryngoscope is represented by the blue line, it demonstrated significant improvement in first attempt success with increasing year of residency training. However, its success rate was the lowest at all levels of training. The hyperangulated blade video laryngoscope is represented by the red line. It had the greatest increase in first attempt success between postgraduate year 1 and 2, but then it demonstrated no significant increase in first attempt success between year 2 and 3. It's hard to know if this is a permanent plateau or if increasing success rates above 90% is difficult and requires more deliberate training. The standard geometry blade video laryngoscope is shown in green. It demonstrated no significant improvement in first attempt success from postgraduate year 1 to 2, but then experienced the greatest increase in first attempt success from year 2 to 3. Skill acquisition with this device relies on learning both direct and video laryngoscopy techniques, which may be the reason why the rate of learning is initially slow, but then significantly rises over time. In conclusion, proficiency with each type of laryngoscope was greatest at the PGY 3+ level of training. This demonstrates the importance of continued endotracheal intubation opportunities throughout all years of emergency medicine training. Early on in residency, the hyperangulated blade video laryngoscope had the greatest increase in success rates, whereas later in residency, the greatest increase in first attempt success was seen with the standard geometry blade video laryngoscope. And finally, the laryngoscopy devices capable of performing video laryngoscopy achieved the highest first attempt success rates from all the laryngoscopes. There are many limitations to our study and areas for further investigation, but I just want to thank you all so much for your time, and I really hope that you enjoyed taking a look at our project.
Hi everyone, my name is Yasemin Sultanyanzadeh and I'm an emergency medicine simulation fellow at Mount Sinai Morningside West in Manhattan. And today I'm going to be presenting my abstract that's titled Improve Intubation Efficacy of Contaminated Airway Using Suction-Assisted Laryngoscopy-Assisted Decontamination, also known as SALAD. This research project was born from a personal case that I had. I was an early second-year resident and had a patient arrive in cardiac arrest. My designated role was to intubate the patient. When I went to intubate them, I found that the airway was just a nightmare. There was vomit contaminating the field and I couldn't see anything. After several attempts, I was finally able to intubate them. I'm sure so many of you can relate to having this panic-filled moment during one of your ER shifts. So what I did when I got home immediately was look up a bunch of different ways to help address this problem. And I came across Dr. DeCanto's SALAD technique. So I'm going to just provide a brief overview over discussing this SALAD technique. So first, you're going to use suction to decontaminate the oral pharynx and your airway. Suction is key during your entire technique of this process. Then with the suction continuously advancing, you're going to use your video laryngoscopy blade behind the suction and slowly advance till you get to your vocal cords. The key here is that your video laryngoscopy should be behind your suction in order to prevent your camera on the VL blade from getting contaminated. Once you're far enough advanced and you can visualize the esophagus, you need to leave the suction in the esophagus. This will continuously decontaminate your airway. Then you'll have a beautiful visual of your vocal cords and you can advance your ET tube. So after learning the SALAD technique, I really wanted to bring this to life and decided to make a SALAD simulation education model for our residency program. The goal of this project was to teach residents the SALAD technique and also to evaluate the usefulness of SALAD in a contaminated airway. A little bit about our mannequin setup. So we had a water cooler here, as you can see, and in order to mimic vomit, we used a viscous gelatinous material. And then we used a garden hose to then connect that to the mannequin's esophagus and was able to use a power drill to move all of this vomit forward into the airway. And then the participants were given a chance to intubate. The purpose of the study was to evaluate a few different components of the SALAD technique. One being time to successful intubation, second, the number of attempts, and third, the comfort and preference of intubating a difficult contaminated airway. For our methods, this SALAD simulation model was presented during a residency conference day. So we had PGY 1, 2, and 3 EM residents who participated, and there were about 38 residents total. They were then randomly divided into two groups, either the interventional SALAD group or the control group. The interventional group was briefed by having an educational session and discussion about the SALAD technique and then a live demonstration. They were then given the opportunity to attempt to intubate. The control group did not receive a briefing and was just instructed to intubate with the same airway head that was contaminated with vomit with their own intubation technique. Our quantitative results are listed below. We found that the time to successful intubation was faster with the SALAD group, almost by 2.5 times. We also found that the SALAD group was able to successfully intubate on the first attempt, and that the number of attempts for the SALAD group was fewer compared to the control group, and all of these values were significant. I just want to take a moment to highlight these different components. I think all of us can relate in having a really critically ill patient in front of us and how a few attempts, a few extra attempts or a few extra seconds could really make a difference and even possibly impact on a patient's outcome. Next, below you'll see the qualitative results, and we used a Likert survey. We distributed a pre and post survey to the participants, 1 being least likely, 10 being the most, and found the following. We found that, that there was an increased comfort in intubating a contaminated airway after learning the SALAD technique. We also learned that there was a preference for using video laryngoscopy as their primary management tool compared to the traditionally thought direct laryngoscopy that wouldn't have the difficulties of the camera getting contaminated. And lastly, we found that the simulation model was effective as a teaching method for teaching SALAD. The limitations for the study were that there was a small sample size, the participants had varying intubation skills, and it was a single center site. In conclusion, we found that the SALAD technique enhances intubation efficacy and improves confidence in intubating a contaminated airway. I'd like to thank all my mentors and faculty members who helped create this project, and here are my references. Thank you.
Hi, my name is Aaron Licht, and I'm a second-year medical student at the Warren Alfred Medical School. And today I'm going to be presenting on airway management trends following out-of-hospital cardiac arrest protocol changes in Rhode Island. For disclosures, this research was supported by funding from the NIH through a T35 grant. So a little background. I'm sure many of you are familiar with the CARES database, which tracks out-of-hospital cardiac arrest data in a number of different states throughout the country. Rhode Island is not a member of the CARES database, so we are unable to track our outcomes for out-of-hospital cardiac arrest data. And we define out-of-hospital cardiac arrest as any cardiac arrest occurring outside of the hospital setting. As a result of this, my mentor, Dr. Nicholas Asselin, created a database called Ripcord, which essentially serves as CARES for the state of Rhode Island, so we can track our own out-of-hospital cardiac arrest data. Several years ago, it was realized through the Ripcord data tracking out-of-hospital cardiac arrests in the state that there were a number of unrecognized esophageal intubations in the setting of out-of-hospital cardiac arrests, which is a never event. As a result, the Rhode Island Department of Health, based on past studies that have been done, such as the PART trial and Airways 2, released an emergency advisory asking that in the setting of out-of-hospital cardiac arrest, supraglottic airways be the prioritized airway used by emergency medical services crews. So the goal of this study was to track EMS adherence to this new airway protocol that prioritizes supraglottic airway, or SGA, use over endotracheal intubation in out-of-hospital cardiac arrests. And we also wanted to evaluate the efficacy of this protocol change, and we wanted to see how it affected out-of-hospital cardiac arrest outcomes. We did this by gathering data from EMS run sheets and electronic medical records from lifespan affiliated hospitals, which included 3 of the hospitals in the state. And we split these up into an interrupted time series, which was created demarcating different protocol changes that have occurred within the state. And you can see here in blue when the Airway protocol was implemented, and then we also looked at data before and after it. I don't want to spend too much time on the population and hospital demographics, but we did have 1,304 different cases of out-of-hospital cardiac arrests that qualified for this trial or for this study. And generally speaking, the populations between the different time periods were fairly similar. So here are some of our results. This table here looks at airway utilization over time. So you can see the different time periods at the bottom, looking at before the Airway protocol was implemented and then when it was implemented. And in yellow, you see the percentage of airways that were endotracheal intubation in the setting of out-of-hospital cardiac arrest. And in blue, you can see the percentage that were supraglottic airways. And you can see that by the time the Airway protocol is implemented, the majority of airways being used are supraglottic airways in the setting of out-of-hospital cardiac arrest. So this shows that EMS crews were indeed using supraglottic airways and prioritizing them in the setting of out-of-hospital cardiac arrests. We also looked at the effect on patient outcomes. So we did this by looking at CPC scores by airway type. So here in green, you can see favorable CPC scores or neurological outcomes with CPC scores of 1 or 2. And in blue, you can see unfavorable neurological outcomes with CPC scores of 3 or 4. You can see that looking at the endotracheal intubation part of the graph versus the supraglottic airway part of the graph, the results are nearly identical, which would support the use of supraglottic airways, showing that they do not have any adverse effects on patient outcomes. That being said, there are a very small number of patients who survive out of hospital cardiac arrest, so this is somewhat limited by sample size. We also stratified our results looking at success rate of airway insertion by provider. So you can see that for endotracheal intubation, the success rates both for paramedics and for cardiac EMTs are on the lower end in the 60s. Whereas for supraglottic airways, the success rates are much higher, 95% plus for both paramedics and cardiac EMTs. So this again supports the use of supraglottic airways in out-of-hospital cardiac arrest. Another interesting thing that we noted here was that the success rate for endotracheal intubation was a bit higher for paramedics than it was for cardiac EMTs, with results trending towards significance. And we think this might warrant further investigation of the use of endotracheal intubation at the cardiac EMT level. In conclusion, there was indeed an increased frequency of use of supraglottic airways by EMS crews following the emergency advisory. Neurological outcomes were similar between supraglottic airways and endotracheal intubation, which supports the use of supraglottic airways. And there was also a trend towards higher overall success for endotracheal intubation with paramedics over cardiac EMTs, which may warrant some future investigation. For limitations, this study is a retrospective study, and thus is prone to forms of selection bias. We only have records from 3 of Rhode Island's hospitals, and thus we may miss data from other hospitals in the state. And there might be something of a survival bias, as Rhode Island Hospital and the Miriam Hospital are the main PCI centers in the state. These are my references. And I'd like to acknowledge and thank my mentor, Dr. Nicholas Asselin, and of course, all the other wonderful researchers that I worked with. Thank you.
Hello, my name is Namal Sandavaratna, and I am a second-year medical student at the Albert Einstein College of Medicine. Today, I will be presenting the results of a study that uses in situ simulation to improve the airway management of patients with COVID-19. Please note there were slight changes to the title and data in this presentation from the abstract. In the spring of 2020, New York City was the epicenter of the COVID-19 crisis nationally. The hospitals in our medical system were particularly hard hit. This includes White Plains Hospital in Westchester County, an affiliate of the Montefiore Health System. As the numbers slowly began to decrease, we held department-wide debriefs and conducted surveys. One of the greatest areas for potential improvement identified was COVID-19 airway management, especially in the areas of infection control, equipment, and communication during intubation. In order to address these issues, we decided to apply in situ simulation as a quality improvement tool. This involved using simulation not just to identify threats, but also address and reassess them. In order to accomplish this, we used the model for improvement. During the planning phase, we trained those involved with the study and discussed our objectives. During the do phase, we performed 10 simulations in the emergency room. During the study phase, we analyzed the latent safety threats and decided how we would address them. And the act phase involved us implementing the suggested changes. We ultimately completed 3 cycles of simulation. This was a low-fidelity in situ simulation performed in the emergency department with multidisciplinary teams. As you can see on the left, we streamlined our setup to be easily stored and cleaned, and our simulation required no extraneous staff. Please see our reference Jaffrey et al. For details on safety considerations for in situ simulation in COVID settings. Our scenario was the emergency airway management of a patient with COVID-19 associated respiratory failure with worsening hypoxia despite BiPAP, thus prompting participants to consider intubation. Following the scenario, we conducted a debrief utilizing a systems focus adapted from Dubé et al., as you can see in the figure on the right. We focused on systems-based latent safety threats rather than individual learner objectives, and when permitted, solutions. The entire simulation and debrief were completed in 15 minutes. Here are the demographics of who participated in the first 2 cycles. 10 simulations were performed per cycle. As you can see, we had multidisciplinary teams that were truly representative of our clinical workforce, such as physicians, APPs, RNs, RTs, and NTs. Our first cycle found a total of 78 LSTs across the 10 simulations in the 3 categories of infection control, equipment, and communication. A few high-frequency safety threats are highlighted here. We prioritize latent safety threats and interventions by urgency. Between cycles 1 and 2, we focus our intervention on infection control and equipment issues. Between 2 and 3, we focus on addressing communication issues. For example, in the infection control category, many participants had difficulty finding and disposing of PPE, so we upgraded our old infection control cart to one that was easily identified and clearly labeled. In the equipment category, it was difficult for participants to find airway equipment since it was not in a centralized location, so we created an airway cart that housed all relevant airway materials. The cart was well labeled and contained a menu which described its contents in detail. The upgraded airway cart experienced great success in the emergency department, with it being used in 80% of the intubations from November to February with an N of 20. Between cycles 2 and 3, the team focused on improving communication skills. We implemented a huddling system using electronic devices such as Apple Watches to notify team members every 4 hours to huddle with their teams. During that time, no patients were assigned, and the huddle focused on team culture, check-ins, running the list, and pre-designated roles in the event of a resuscitation. To analyze changes in LST frequencies over time, we utilized run charts. The total perceived latent safety threats shows a gradual decrease in threats over time and per PDSA cycle as expected. In the equipment run chart, we note a shift downwards after the first PDSA cycle was completed, and this was maintained for the remaining simulations. These results suggest that somewhere between 10 and 20 simulations are needed to identify latent safety threats associated with equipment. In communication, there is a trend towards identifying fewer threats during PDSA cycle 3, likely because of the structural communication-focused interventions implemented immediately before cycle 3. Lastly, in infection control, perceived latent safety threats are steady across the 3 cycles. The fluctuation observed is curious and deserves further scrutiny. One notable limitation is that we relied on standardized debrief forms rather than using AV recording equipment to measure LSTs. This was in order to minimize equipment and staffing required to conduct the study, as we were performing these often in closed COVID units. Also, we lacked direct patient-centered outcomes in order to determine the effect of our interventions, not only on systems, but also on patient care. For our next steps, we would like to compare the results at White Plains Hospital to other hospitals in our health system. This project is being simultaneously carried out at 4 other institutions, and our collaborative meets monthly to discuss the project. To address our lack of patient-centered outcomes, we plan on investigating the impact of our interventions in clinical use, the communications category in particular. Lastly, the impact of this project goes beyond airway management. We are currently using the same framework in other areas, like the cardiac catheterization lab. I'd like to give special thanks to my mentors, Dr. Farouk Jaffrey and Dr. Christina Yang, and all of those involved with this project. Thank you for listening, and please ask any questions.
Welcome. My name is Rebecca Thord. I'm a senior resident at the Christus Health Texas A&M Emergency Medicine Residency. The title of my study is Patient Satisfaction with Subdissociative Dose Ketamine versus Morphine for the Emergency Department Treatment of Abdominal Pain. I have no financial conflicts or disclosures. I'd like to recognize my co-authors, the doctors Youngblood, Shu, Torres, and Richmond. In the 1990s, regulatory agencies placed an increasing focus on the epidemic of untreated pain in the hospital. The Joint Commission adopted a slogan to encourage pain as the fifth vital sign. They encouraged prioritizing the treatment of pain. Opioid prescription rates increased dramatically over recent decades. As opioid overdose deaths became the #1 cause of accidental death in the US, researchers have turned their focus on the need to find alternative means to treat pain. Investigators have previously provided evidence that ketamine improved ED pain scores. Carlo et al. Demonstrated that ketamine was safe and effective at low doses in treating pain. Sin et al. Found that when ketamine was administered as an adjunct to morphine, the patient had better pain control and required less opioids overall. Poorman et al. Found that low-dose ketamine effectively treated pain while having an acceptable adverse effect profile. There is limited previous data regarding patient satisfaction following treatment with ketamine for analgesia. The objective of our study was to test the null hypothesis that there would be no difference in patient satisfaction scores for patients treated for abdominal pain with ketamine versus morphine. In terms of methods, this was a single-blinded, randomized, controlled trial conducted at an urban emergency department. We enrolled a convenient sample of consenting adult ED patients 18 years and older who had a chief complaint of abdominal pain greater than 5 out of 10 on a VAS scale. Informed consent was obtained. The patients were randomized into 2 groups. The study group received ketamine 0.3 milligrams per kilogram IV. The control group received morphine 4 milligrams IV. Both medications were pushed over 3 to 5 minutes. Each drug was administered by a physician to ensure patient blinding. Patients were reassessed at 30 minutes post-treatment and given a survey to ascertain their VAS pain score and satisfaction on both a 5-point Likert scale as well as a VAS scale. For our statistical methods, the categorical data was analyzed by chi-square. The continuous data was analyzed by t-tests. Linear and multivariate regressions were performed to control for confounding. The study required 16 subjects in each group to have an 80% power to detect a 2.5 VAS satisfaction difference. The primary outcome parameter was to compare satisfaction scores between patients treated with morphine versus ketamine, respectively. With respect to our results, 32 patients were enrolled in this study. 16 of them received ketamine. Patients were similar for the following characteristics. 69% were female. The mean age was 46 years old in the morphine group and 39 years old in the ketamine group. Mean BMI was 31 and 30, respectively. Pre-treatment pain score was 8.3 and 8.2, respectively. Race was similar between both groups. Patients who received morphine were more likely to require rescue medication, 56% in the morphine group and 19% in the ketamine. Patients who received morphine had less reduction from initial pain score, an average of 2.9 points in the morphine group and 5.1 points in the ketamine. There was no difference between the 2 groups in Likert satisfaction ratings of 5 and VAS scores. We found within a linear regression model that ketamine was associated with larger pain score reductions, but VAS satisfaction was similar between both groups. Within a multivariate regression model, Likert scores were similar between the 2 groups as well. By way of discussion, investigators have previously illustrated that ketamine has excellent efficacy as an analgesic in the ED. Sin et al. Demonstrated that ketamine was an adjunct to morphine. Patients who received ketamine as an adjunct had a higher mean satisfaction score with their pain management with no serious adverse events. Balzar et al. Demonstrated that low-dose ketamine and morphine had similar analgesic effectiveness within 60 minutes of administration with comparable safety profiles. Our study compared ketamine at 0.3 milligrams per kilogram versus morphine at 4 milligrams. Other studies have used weight-based morphine at 0.1 milligrams per kilogram. We chose to use 4 milligrams of morphine as this is more reflective of true ED physician prescribing practices. In our study, ketamine was effective in reducing patients' pain. There was no difference in patient satisfaction with morphine versus ketamine. Limitations of our study were our small sample size. Larger studies are needed to confirm our findings. Our study population was predominantly Hispanic and lower income. Our results may not be generalizable to other populations. Also, we only evaluated patients with abdominal pain. In conclusion, patients treated with ketamine had a larger reduction in their pain scores and required rescue pain medication less frequently than those treated with morphine. The concern with utilizing ketamine is that it will negatively impact patient satisfaction due to the adverse effect profile. However, in our study, patient satisfaction was similar in both treatment groups. Thank you.
Hi, thank you for having me. My name is Skylar Chenard, and I'm a third-year emergency medicine resident at the University of Iowa. I'll be talking with you about substance use history's impact on acute pain management in patients discharged from the emergency department. I have no disclosures or conflicts of interest. In the setting of a national opioid crisis, where 10% of the U.S. population has or has had a substance use disorder, emergency physicians need to be aware of this history in each individual patient when treating acute pain. Acute pain management is something we encounter every day. 17% of patients discharged from the emergency department are discharged with an opioid medication. 10% of these patients have at least one indicator suggesting risk for inappropriate use. Over or under treating pain is concerning. State legislation has limited the amount of opioid analgesia that can be prescribed to prevent overtreating pain. Undertreating pain is also problematic and negatively impacts patients' pain trajectory after an acute injury. The objective of our study was to examine whether we treat acute pain differently in patients with and without current or past substance use disorders by quantifying the proportion of patients who received opioid analgesia in the ED and at discharge, and by quantifying the amount of opioid analgesia received in the ED and prescribed at discharge after acute fracture, which is how we chose to define acute pain. This was a retrospective cohort study done at the University of Iowa, which is a 60,000 visit tertiary care center. The charts that were reviewed were from visits between January 1st, 2016 and June 30th, 2019. We included adults aged 18 to 65 years old who had an acute fracture that were able to be discharged from the emergency department. We excluded patients who had chronic opioid prescriptions, chronic pain syndromes, who were prisoners, or who had an active cancer diagnosis. Patients with a history of substance use disorder were matched with a patient without history of substance use disorder by gender, age, and insurance type. Our primary outcome was the proportion of patients who received opioid analgesia in the ED and at discharge. Our secondary outcome was the amount of opioid analgesia received in the ED and prescribed at discharge. We standardized this amount into milligram morphine equivalents. We had 117 patients in each group for a total of 234 patients. 75.2% of patients were male, and you can see the age distribution here. In both groups, the most common mechanism of injury was fall and assault. Patients with a history of substance use disorder were more likely to be intoxicated and have comorbid psychiatric and other health conditions. 48.7% of patients with a history of substance use disorder and 58.1% of patients without history of substance use disorder received opioids in the emergency department. Based on the adjusted odds ratio, patients with a history of substance use disorder were 1/3 as likely as patients without this history to receive opioids in the emergency department. 56.4% of patients with history of substance use disorder and 68.4% of patients without history of substance use disorder received an opioid prescription at discharge. Based on the adjusted odds ratio, patients with history of substance use disorder were half as likely as patients without this history to receive an opioid prescription at discharge. The amount of opioids administered in the emergency department significantly differed between groups. Patients without history of substance use disorder received significantly more opioids in the emergency department than patients with history of substance use disorder. There was no significant difference in the amount of opioids prescribed at discharge between the two groups. Overall, patients with history of substance use disorder were less likely to receive opioids in the emergency department, and when they did, the amount that they received was less than patients without this history. Patients with history of substance use disorder were less likely to receive an opioid prescription at discharge, but when they did, the amount that they received was the same as patients without this history. In the future, a survey could be added to similar research to assess whether patients felt that their pain was undertreated. Additionally, the statewide prescription monitoring programs could be utilized to assess whether opioids were sought elsewhere following discharge. However, this is not allowed in the state of Iowa. It is appropriate for emergency providers to use caution when using opioids to treat pain in patients with a history of substance use disorder. However, it is also important to remember undertreating pain can be detrimental. In the future, developing guidelines on how to best treat acute pain in patients with a history of substance use disorder would be helpful so that we do not over or undertreat their pain and negatively impact the cycle of addiction. Thank you.
Hello, my name is Dr. Adam Rhodes. I'm a third-year Penn Fellow at Maimonides Infant and Children's Hospital in Brooklyn, New York. I want to say thank you to SAEM for giving my team the opportunity to present our pilot study, Ketaban, nebulized ketamine for pain control in the pediatric population. First things first, all authors have no actual or potential conflict or financial interest. Now let's talk about some background information. We know ketamine is a non-selective NMDA receptor antagonist that provides a wind-up phenomenon at the level of the spinal cord and central nervous system. This unique property decreases pain by diminishing central sensitization and providing hyperalgesia. It can be used in a procedural sedation at full dissociative dose and also for analgesia at subdissociative dose, which is where we will focus our attention. At this time, we can give subdissociative ketamine via IV, IM, and intranasal routes. We know this by looking at the timeline of ketamine. It was first synthesized in 1962 and first used clinically in 1970. Over several decades, numerous studies have been done looking at subdissociative ketamine, with specific guidelines by ACIP being approved in 2018. In the last decade, studies have looked at nebulized analgesics, and there have been studies looking at nebulized ketamine in post-intubation and in asthmatics. This leads us to our question. Can nebulized ketamine provide safe and effective pain relief in pediatric patients presenting to the ED? We found no prospective randomized trials evaluating nebulized ketamine in managing acute painful conditions in the ED. Our objective became to compare analgesic efficacy and rates of side effects of subdissociative dose ketamine via nebulization at different dosages for pediatric patients. Our study is a prospective randomized blinded study with its format similar to its sister study looking at nebulized ketamine for pain in adults. We used a breath-actuated nebulizer termed BAN. For those not familiar with BAN, here are a few images. It is a closed system with a mouthpiece with patient's inspiratory drive causing inhalation of nebulized ketamine. We chose this secondary to its ability to allow us to measure how much medicine the patient was given, to allow the patient to have full control of how much medication is inhaled, and its ability to prevent any medication lost in the environment. We have 3 study arms in order to optimize the dose, and these are based on several studies looking at ketamine via intranasal route and nebulized ketamine for post-op sore throat and asthma. Our hypothesis is subdissociative dose ketamine via BAN at 1.5 milligrams per kg will provide better analgesia at 15 minutes with similar rates of side effects compared to the lower dosing arms. Our inclusion criteria looked at patients 7 to 17 years of age. The 18 and older patients were considered for in our sister study, and we did not look at kids younger than 7 due to the inability of younger children not properly being able to use the device. Patients were included if they presented with acute painful condition with pain scores equal to or greater than 5 on a standard scale. Below are a few examples of our painful conditions included and some examples of our exclusion criteria as well. Our primary outcome is to look at pain scores and side effects at 15 minutes post-nebulization. Secondary outcomes include pain scores and side effects at 30 minutes and 60 minutes post-nebulization, along with if additional pain medicines were needed. Side effects were looked at using previously validated SIRSA and RASS scoring system. Here's an example of our validated numeric basis pain scale that we used. Looking at previous studies, we are looking for a minimum meaningful difference of 1.3 on the pain scale between dosages. Given power of 80% and an alpha of 0.05, we need 34 patients per each dosing arm. Based on the specific outcome we are looking at, we will use these various statistical tests. Our recruitment process consists of our research team who are contacted once a patient meets inclusion criteria, and here are the steps that they take during the study. Here's an example of our data collection sheet. Next is our demographics. We see that we have about the same number of participants in each arm with similar means and medians for age and weight. The only noticeable difference is that there were more males in the 1 milligram per kg arm. Secondary to the COVID pandemic, which drastically affected our recruitment, our sample size is very small, and at this time we have not done any statistical tests. We are now going to look at pain scores. Each arm shows the range of pain scores with dashed line representing the median and X representing the mean. What we see is that each group have similar pain scores prior to the medication, with all having a decrease in pain over time, emphasizing nebulized ketamine's utility to improve acute pain. Though no conclusion can be made at this time, we do want to highlight that at 15 minutes, only the 1.5 milligram per kg arm had patients with a pain score of 0 and overall had the lowest mean and median compared to the other 2 study arms at that time. As for side effects, only 2 patients using RAS had some form of agitation and sedation that resolved at the end of the study. As for SIRSA, we will only be looking at the side effects that patients had complaints of. First, we will look at fatigue. We see overall low mean and medians in all 3 study arms and gradual resolution over time. Next is dizziness, showing similar results, but what is worth noting is the smallest dosing arm had the largest scores after 15 minutes. Lastly is headaches. This side effect also shows variable results with all arms having low overall means and medians. What is interesting is the highest dosing arm had 0 patients elicit headache. Once again, at this time, we are presenting the pilot study. We know there are several potential study limitation questions to the overall study. With that said, we feel that the pilot study confirms our suspicion that nebulized ketamine has utility in the pediatric ED, and the larger study will help us answer our questions and objectives. As for the future, our case series of the first 5 cases has been accepted by the Turkish Journal of Emergency Medicine, and we are continuing the recruitment with a goal of 120 total patients needed. These are our references. Thank you for your time, and I look forward to answering any questions.
Hello, my name is Joe Stinnett. I'm one of the emergency medicine residents at Washington University in St. Louis. I'm going to be presenting my research on dexmedetomidine use in the emergency department. I have no financial disclosures. The management of sedation, analgesia, and anxiolysis are foundational principles in the ED. I'm going to be focusing on dexmedetomidine, which is a centrally acting alpha-2 receptor agonist. It provides its clinical effects with sedation, anxiolysis, and analgesia, but has the added benefit of preserving respiratory drive. The adverse effects associated with this medication, however, do include bradycardia and hypotension. Data from mechanically ventilated ICU patients has demonstrated reduction in delirium and ventilator duration with dexmedetomidine use versus benzodiazepines. It's also been shown to provide effective facilitation with non-invasive positive pressure ventilation and may be associated with improved outcomes in those scenarios as well. There's been prior major randomized controlled trials looking at ICU data with dexmedetomidine. However, there's limited ED data to determine the safety and efficacy profile of dexmedetomidine in the ED. The objectives of this study are to characterize the use of dexmedetomidine in the ED and describe the incidence of adverse events and explore the factors associated with adverse events among patients receiving dexmedetomidine in the ED. The design of this study was a single center retrospective cohort at an academic university affiliated teaching hospital with an annual ED census of 90,000 patients. It was completed over a 30-month time period. The inclusion criteria were patients over the age of 18, as well as patients who received dexmedetomidine in the ED for any indication. The primary outcomes were the incidence of hypotension and bradycardia, and we also looked into secondary outcomes of ventilator, ICU, and hospital-free days, as well as hospital mortality. The primary outcomes with hypotension and bradycardia were defined off prior randomized controlled trials, looking at dexmedetomidine use, and this included systolic pressures less than 80, diastolic less than 50, or a greater than 30% decrease from baseline. And for bradycardia, it was defined as a heart rate less than 40 or less than 60, or a decrease of 30% from baseline as well. The total number of patients included in this study ultimately came down to 103, with a subgroup of interest including those that were mechanically ventilated in ED. Our table 1 was our baseline characteristics, and we also looked at ED process of care variables, which are listed in this table as well, including length of stay, vasopressor use, and any need for mechanical ventilation. We also looked at baseline laboratory values as well. There was no significant difference between the patients experiencing an adverse event versus those that did not from a baseline characteristic standpoint. For sedation characteristics, all dexmedetomidine related data in the ED was collected and included indications for its use, time from ED arrival to order, and time from order to drug administration, as well as duration of use in the ED, its dosing, and patient's mental status at initiation. The results showed that the most common indication for dexmedetomidine was in fact acute respiratory failure and facilitation of either positive pressure ventilation or sedation for mechanical ventilation. There was also a noted significant delay in time from ED arrival to order of the medication, up to 156 minutes. This is potentially related to the lack of the medication being in this institution's particular Pyxis system in the ED. Also in this table, it's noted that there was relatively even distribution of co-administered analgesics listed below, including fentanyl, propofol, benzodiazepines, ketamine, and haldol. The median starting dose in the ED was 0.4, which is consistent with the order protocol set that we had in our particular institution. There was relatively low doses of dexmedetomidine used in the ED as well. For adverse events, again, for our primary outcomes looking at hypotension and bradycardia, we did have roughly 59% of our patients develop hypotension and or bradycardia. And these patients that were experiencing these adverse events, not surprisingly, did receive fluid boluses or vasoactive medications. Dexmedetomidine was stopped in 8% of patients due to an adverse event. However, overall, patients with adverse events had similar clinical outcomes from a secondary outcome standpoint, with ventilator-free days, ICU-free days, hospital-free days, and mortality. Limitations to this study include its overall design of being a retrospective single-center study, also had a relatively small sample size of 103. However, at the time was the largest ED-based dexmedetomidine study to date, and documentation was limited in certain aspects regarding sedation depth as well. Conclusions from this study include that dexmedetomidine was used for multiple indications in the ED, most commonly for patients with acute respiratory failure. Secondly, while adverse events with hypotension and bradycardia were relatively common, the event rates were similar to those experienced in the large RCTs done in ICUs. Also, the number of patients that had dexmedetomidine stopped secondary to an adverse event was relatively low at 8%, suggesting these adverse events were overall clinically well tolerated. And then third, our data suggests that ED-based dexmed protocols can be effectively implemented similar to its roles in ICU for analgesia, anxiolysis, and sedation. Thank you for your time, and I'm happy to take any questions.
Hi, everyone. My name is Alexandra Baudin. I am a master's student in psychology at the University of Montreal. I am grateful to have the opportunity to present you the study on the chronicization-associated factors in a population with acute pain. And my supervisor is Dr. Raoul Daou from the Montreal Sacré-Cœur Hospital. This project is a sub-study of the UPAM project, which received a grant from the Canadian Institute of Health Research. To put you in context, in Canada, 1 in 5 people suffer from chronic pain. And for our part, we have mainly focused ourselves on the definition according to which pain is generally considered chronic when it occurs in 1 or more physiological regions, when it persists or recurs for more than 3 months, and when it's associated with emotional distress or functional disability, such as disruption in daily activities and social life. For the quality of life, it refers to several dimensions, but it is the physical and mental factors that explain its greater reliable variance between 80 to 85%. And to this day, we know that the quality of life of people with chronic pain is affected. However, no study has evaluated whether the quality of life preceding an episode of acute pain could predict its chronicization. It brings us to verify whether the quality of life of an individual preceding an episode of acute pain would allow us to identify those people who are at greater risk of developing chronic pain. And our hypothesis is that patients with a good quality of life preceding their acute pain will be less likely to develop chronicization of their initial pain. So to be included in the study, patients must be 18 years old or older, and they must have been in pain for a maximum of 2 weeks before their visit to the emergency, and they must have received an opioid prescription at their discharge. So participants are recruited daily, 24 hours a day, by emergency physicians and are contacted by a research assistant. On the first day, the SF-12 questionnaire is administered to determine their quality of life during the 2 weeks preceding their visit to the emergency room. The SF-12 is one of the generic questionnaires on the quality of life most used to assess the physical and mental components of a patient. and it allows us to determine the average health threshold. 3 months later, a follow-up is done with them to know, among other things, their pain intensity on the numeric rating scale. And for the statistical analysis, first, the sociodemographic variables of the patients who participated in the 3-month follow-up were compared with those of the patients who drop out using t-test and chi-square test. After that, the physical and mental dimension were compared between patients who developed chronic pain versus those who did not develop chronic pain at 3 months with t-test again. And then a logistic regression was performed to determine whether the pre-event quality of life predicts the chronicity of post-event pain by controlling the variables that may act on the results. So the results show that 25% of the participants dropped out on the way. We tried to understand why, or if there was something that would have set them apart, but no differences was found between those who completed and those who dropped out. So it's still positive despite the 25% of dropouts. To give you a little idea of our population, the study includes 579 participants and 52% were men. And for the diagnosis, the majority of diagnoses are musculoskeletal. For the prescription, the opioid prescription, it's mostly morphine. And as you can see, of the 579 participants, 184 developed chronic pain 3 months later. So it is still 32% who reported having pain equal to or greater than 4 on the numeric rating scale. And as you can see here, our results are significant and show that patients with poor pre-event quality of life are more likely to develop chronic pain 3 months later. And there will therefore be a negative relationship between the quality of life and the chronicization of pain. Obviously, it's important to mention that these are only preliminary results. It must be considered that there was 25% dropout during the study. However, there are no differences between participants who participate until day 90 with those who dropped out along the way. And also, chronic pain is a term with many variations in its definition. So the results might have been different with another definition of chronic pain. It is still a difficult subject to define objectively. And to finish, the results still raise interest in replicating the study with a full cohort. We believe that it would be relevant to offer a follow-up with patients with a poor quality of life pre-event and presenting to the emergency room with acute pain in order to avoid the development of chronic pain over time. So thank you very much. If you have any questions, let me know.